Good evening, everybody. I want to welcome you all to our event here with our authors event series at Brookline Booksmith. We are featuring Dr. Farzon Nahvi and this wonderful book, Code Gray, Death, Life, and Uncertainty in the ER. Before we hear from this brilliant author, we request that you keep your mobile phones on silent during the event. If you haven't yet picked up your pre-ordered book or you would like to buy a copy, I will be back here selling the books, and you can then have one so you can actually join the signing line. Speaking of the signing line, we're going to have it go right through the store this way towards the cooking section, along the art books, so you have pretty things to stand and look at while you're in line. And then the last but not least, we do have a live stream going over here, so unless you want to be on the interwebs, I would request you don't stand right here. Just a couple simple things. But yeah, first I want to welcome our moderator for this evening, Gabrielle Emanuel. Thank you so much for joining us. She is a senior health reporter for WVUR. Her work has appeared on NPR, This American Life, as well as in the New York Times and The Atlantic. She got her doctorate at Oxford as a Rhodes Scholar, and she predominantly covers health and social welfare stories, which we are very excited to welcome her to have this conversation. So thanks for being here. And then our delightful featured author this evening is Dr. Farzon Nahvi. A fellow New Englander, is also an ER physician at Concord Hospital in Concord, New Hampshire, and a clinical assistant professor of emergency medicine at the Jesse School of Medicine in Dartmouth. Prior to this, he worked as an ER physician and a clinical assistant. He was a professor of emergency medicine in hospitals all across Manhattan. He is also a graduate of Cornell and NYU Grossman School of Medicine. He has written for the New York Times, the Washington Post, The Guardian, the Daily News of New York, New York Magazine, and other publications. And in April 2019, he testified as an expert witness before Congress in the nation's first Medicare for All hearing. But of course, we're here to talk about the book. So Code Gray, Death, Life, and Uncertainty in the ER is a beautifully written memoir which takes place during one of Dr. Nahvi's routine shifts at an urban ER. The book explores everything from early days of COVID outbreak to the perennial glaring inequities of our healthcare system. And through this, Dr. Nahvi invites us as readers to reflect on life and shifts at the ER and how gut-wrenching and unpredictable life can be manifest in this 21st century. So I am very excited to hear this conversation, and I want you all to join me in welcoming these wonderful speakers to our stage.
Hi, it is good to be here. I started reading this book while sitting in the ER with my mother, who had just broken her leg, and it was just as you described, an overcrowded ER where there were gurneys in the hallway lined up, and they were numbered the way you would have numbers on a room. So I'm sure it was a regular occurrence that they were overcrowded. But it was, I won't recommend you read it in the ER, but it was a fantastic place to read it because I felt like I had the internal thoughts of a ER doctor with all the sights and scenes to accompany it. I just wanted to make one comment, which is that we are hoping to open it up to questions and would love to get as many thoughts and perspectives and questions as possible. So be thinking as we chat about what you want to ask. But just to start off, I wanted to hear about the inspiration for this book. How you decided to write a book, where this came from. Was it this one story, or did you know that there were things to write about before?
Well, first I just want to say thanks for coming out. It's like a miserable day, so I appreciate it. I don't know, there was a specific story that was the inspiration for this book, and it was the story of Lola, who was kind of the main character of the book, if there's a character in that way, and it was just my interaction with her that really just left me kind of unsettled, and kind of had these thoughts that I didn't realize were percolating within me that were percolating, and it just, I didn't intend to write a book. I kind of just had these thoughts that were within me that I just needed to get down, and one day just kind of came out of me. So I was actually just walking my dog in Central Park, and I just kind of ran to the nearest doorman building, and I think he thought I was having an emergency. I was like, I need some paper now. And then he just gave me like 6 sheets of paper, and I just started writing. And it was pretty much the conflict I had of, so story, this patient, she's in her 40s, she comes in cardiac arrest and she's dead. And then I was ready to call her death and call the time of death, but then the paramedics told me that the husband's, he's going to be coming in any second. So at that time I kind of made the decision that the way it usually happens in the ER is that either the family's in the room in real time watching everything you're doing, or they're kind of escorted to a different family room and then we have a discussion with them afterwards. But in this circumstance, what I was really worried about, despite all the things that were happening medically and that this lady died, was that I was worried that the husband would come in and kind of come in at the wrong time and just see it in the wrong way. And for some reason that really bothered me. So I made the decision to continue the code and just keep going for a few more minutes so that he wouldn't come in that moment as we were calling a time of death, because that just felt so wrong to me. And then we did that, and then I guess for a few weeks it was just bugging me that I made that decision. It was just bothering me so much. And I didn't realize why, but then I realized I was trying to do it for the right reasons, to kind of make sure that he wasn't exposed to that in the worst possible way. But then I realized by continuing this medical code on the person that I knew was dead, I kind of had this thought bugging me in the back of my head was, did I just do this thing to this lady as like medical theater almost, like for the husband's sake? And I felt a little fucked up, like it didn't feel right. So I just had this thing that just was bugging me about her, and I needed to kind of figure it out. And that's how the book started, just kind of going through the process of seeing how I felt about that. And I think that's how a lot of these things in this book, and as physicians and people that work in a hospital that are part of this, they exist within you, even if you don't think that they do, and they're deep down in there. And I think part of the process for writing for me was sorting it out and figuring out what I really felt about it.
So I want to dig into the specifics of all of the story, but if we leap forward, has writing the book left you more settled?
Yeah, big time.
Yeah.
And I don't know that it's something that like people always say like you should tell other people to write. I don't know if it's something that like is the way to deal with it for everyone, but for me, for sure. And I'm not like there's people that study writing and go to writing retreats and are kind of big writers their whole lives. And that was never me. It's kind of writing was my way that just kind of came to me as a way of needing to for a lot of this stuff. But yeah, no, it certainly helped me process it and understand it better. Even if it came to no specific answers, just kind of when you write it, you have to be more focused in terms of how you're thinking about it, rather than just having thoughts be scrambling in your brain. You have to be a little bit more organized about it, and that really has helped me quite a bit, actually.
And while you were writing it, my understanding is that's when COVID happened.
Yeah.
So how did that influence the book, the outcome, and your thinking and processing about all of this?
Yeah, so I wrote kind of the book about this lady's story and my interaction with her and her husband in the ER, and the whole book took place over the course of 2 hours. But then COVID happened, and then my editor, he called me and said, we want you to write a COVID book now. And it was very flattering because I'd never written a book before, and all of a sudden I'm given an opportunity to write 2 books. So first I was like, yeah, sure, I'll write a COVID book. But then for like a week I was thinking about it, and then I said no after a while, because I realized that the book that I wrote that ended up being the main arc, it was my COVID book, and had nothing to do with COVID. It took place in a pre-COVID world, but all of the dilemmas and problems with the healthcare system and ethical and medical dilemmas that we see with COVID, they're always taking place. There's nothing unique to COVID. They were just more extreme during COVID. And then when I was toying with the idea of writing a COVID book, I just realized that I didn't want to do that, just because I felt like if you write about these things only in relation to COVID, it gives off the impression that COVID has created these things, or these are unique to COVID, but I don't think that's true. I think these things always existed. I think COVID just highlighted how stressful and kind of complicated, and how our system's so broken. All the things that are always there just highlighted them more. It was more of a clarifying lens. So I wrote an intro that does take place during COVID, and I wrote that because I think it's kind of, you can't write about the ER in 2023 without mentioning COVID. You have to write about COVID. You have to discuss it. But I wanted to use it only as a prologue and use that as a clarifying lens for our everyday. And I think writing about our everyday is much more revealing and interesting than writing about this extreme circumstance.
So before we get into that situation in the everyday, when you wrote about COVID, you had passages, long passages of text messages between you and a group of ER doctors all over the country, is my understanding. And one of the things you point out is, or say, is that you guys were kind of a step ahead of the official guidance in troubleshooting what to do and how to respond to situations. How could you fix that going forward? How could this have been different such that you could have been more supported and guided during this kind of insane time?
I mean, not to be too like emergency medicine centric about my own field, but I think we need ER docs up at the higher levels of the CDC and people making decision-making bodies. I think what we saw was a huge failure of how to make a decision when making decisions tough with incomplete information. Because I think the reason we were a step ahead isn't that just we were on the ground and seeing stuff, it's because the CDC just kept failing to make the call when they had to make the call. And what we hear over and over again was there's not enough evidence to support this. There's not enough evidence to say that this is an airborne disease yet. And for us, it's like, well, yeah, no, there's not enough evidence, but you got to make that call. And if you wait to make that call and it is airborne, then you kind of drop the ball. You have to make that call before you know. And we feel comfortable in the ER making decisions with the incomplete information. We say, hey, if you come in and you look like you're septic, severe bacterial infection that's deadly, I'm not going to wait to find out if the source is a pneumonia or a urinary tract infection and find out what the evidence is. I'm going to cover you for everything just to make sure you don't die until we figure out what it was. And the same can be said about a lot of decisions, about mask use, booster shots, and N95 and airborne disease. The CDC kept just saying, we don't have enough evidence, and for us, we said, yes, that's true, but you gotta make that call. So I don't think, I mean, it's not just ER doctors either. I think anyone that's used to dealing with emergencies gotta be more in these positions. People, like, we put a police chief or a fire chief or someone in the military, that's fine. Someone that can make those decisions, because I think that's where the real problem was.
So if we go to this case, so as you introduced, there's a 43-year-old woman who comes in without a pulse, hasn't had a pulse for 30 minutes, and the way you describe it is that essentially means there's no hope. But yet you continue the interventions that the paramedics have started. Maybe as medical theater, something. Walk us through your thought process. You began to earlier, but what was the thinking and that moment where you had to decide?
Yeah, I wouldn't say the beginning is medical theater yet. It did become later for this particular patient. But even, you know, it's this funny thing where if a patient comes in and they're pulseless for 30 minutes, you know the overwhelming odds are that you're not going to get that pulse back, that if they're dead then they're going to remain dead. But there's also so much happening so fast, and things aren't happening in sequence, they're happening in parallel. You're just getting a ton of information. So while you're getting that information of what's the story, how long were they down for, what happened to them, who were they with, kind of getting all the details, you want to keep things going while you get the information, because if you kind of wait to get that information and then say, oh shit, we should have been doing that, it's too late. So you start everything knowing that 99% of the time you're doing all this stuff for nothing. But every once in a while, you don't, right? If this person was found in a snowbank and they're hypothermic, then they'll be pulseless for 30 minutes and they could totally be revived and resuscitated, because if you're hypothermic, your metabolism is running less and your brain is not needing enough oxygen. So that's fine, and those people can be resuscitated. So there's circumstances that are different, and before you know all the information, you just keep going. So that's that thought process there. But then what you're getting at a little bit later, it did become a little bit more of a funny situation for this particular patient.
Mm-hmm. And there, how did you make the decision? My understanding is you were hoping to influence the experience the husband had in learning about. What was the hope, and what were the kind of dynamics at play in terms of how this might be helpful for him?
Yeah, I mean, I think the honest answer for that, the honest answer is that all these situations, like, they're just really devastating.
Yeah.
and we see it all the time, and we're supposed to be used to it, but we're not. It's just every time it happens, it's like, it's devastating that, young lady died, and you're gonna have to tell her husband that she died and kind of walk him through it. He doesn't know that yet. So part of it is not wanting to have him come in and see that, but a part of it's also like, I want to get my bearings and kind of know what's going on, to slow down, because in a selfish way, it's like, I'm not ready to have that conversation with him yet also. And I hate saying that, but you just kind of want to make sure you're on solid footing and your mind's in the right place, because you're switching drastically, right? You're in the room, someone's dead, you're leading a code, there's a lot of stuff going on, you have your nurses, your techs, and your respiratory therapists, and everyone's there, and you're thinking in a very medical mindset, but then immediately you have to switch to a very emotional mindset and kind of have this social interaction. And it's a stark change, and to navigate that's always it's difficult. Yeah.
At one point you talk about how if somebody's there to see their loved one die,
Yeah.
it might make the grieving process easier.
Yeah.
And I kept wondering while reading that if the type of death matters. I don't know if you have thoughts on that. Like if CPR, which this woman had, it can be brutal with broken bones, might be a different value.
I think, and correct me if I'm wrong, but I'm guessing that your gut instinct is that it's just too much, or it's just too graphic or too awful for a family member to see.
That those scenes replaying in your head could maybe be harder than if it was a peaceful death. I know that sometimes when someone's brain dead, they'll keep them alive just so their family can fly into town or something, and then it's more of a peaceful transition, but this is a very dramatic.
The counter argument to that, though, is that not knowing is more catastrophic, and not being there, not knowing what happens. And that's
totally possible.
That's my personal reaction, and I know for me, if it was happening to my loved one, I would want to be there, even if it's hard to see, because the alternative is to kind of not let someone in the room, right? To escort them somewhere else while this is happening and say, hey, we'll let you in once it's done. But then to know that your loved one is in another room and all this stuff's happening, and then for someone to just come out and tell you that they died, I think. So I'm not saying it's easy to have the family members there, but I think it's easier or better than not being there. And there's research that validates this. There's a lot of studies that show that kind of the grieving process is difficult, but people who are there to witness their loved one as they're dying go on to have a less difficult grieving process over time. So the research validates it, but I think also like during COVID, everyone kind of intuitively got that, right? I think one of the big storylines during COVID was that visitors weren't allowed in the hospitals, and once everyone realized that people weren't there while their loved ones died, everyone just intuitively knew that that's devastating. So I think, yes, it's hard to see it, and yes, it's awful, but the alternative is worse. So not that it's a good thing, not that it's a thing, come on in,
Not come on in, but maybe not continuing it for his sake, or something, you know.
Oh, I see.
I don't know. I was just thinking it as.
Yeah, no, I guess I'm squarely in the camp of, first of all, I do want to say we give the option always. We don't say come into the room. We say, hey, this is happening, it's going to be very difficult. Your loved one doesn't have a pulse, so they're not alive right now. You're welcome to come in if you'd like. And if you don't want to be in the room, that's okay. You can stay somewhere, we'll catch up with you later. So we always give the option. We never say, just come in. But I guess just from being a part of it enough times, it feels that the family members who are there just kind of, they get it in a different way, and just the questions they ask and the way they react. It's really funny. I think, does anyone here work in the ER? So I feel like one of the weird things about the ER is that you could do a lot of work and work your butt off and save someone's life, and that patient might just be like, oh, thanks, great. But then the patients that die, and you talk to their family members, they're just so weirdly appreciative. And it feels so bizarre to me always, because it's like, this person died, we didn't actually help this person, and we did all this work and we helped all these other people. But I think what you realize is that they see the worst possible thing, but they also are just in a different mind state, and somehow they appreciate it, they accept it, being there seems like it helps them. It's just all I have to say.
Tell me, you talk about how hard or how bad the medical profession is about meaningfully thinking and talking about death, or processing it. I guess I'm curious to hear more about that and more about what types of things could help on an individual level, and then also systemically, like what institutions could do to help.
Yeah, no, we just don't do anything. And I don't think that there's some sort of thought process or kind of rationale behind it. I just think that nothing's ever been done, so no one does anything, and you're kind of thrown into this role, and you're around this stuff, and people die, and just no one acknowledges it, and it's really weird. If you've ever been in a room and someone dies, everyone kind of just looks at each other a little bit awkwardly and kind of say, all right, and then people walk around and they just continue their regular day-to-day job, and it's just terrible. There's no organized reaction to it. And one thing that's interesting, my wife's here, Vivian, she's an OBGYN doctor. And one time when she was in training and residency, there was a patient on her floor that died. And it wasn't her patient, it was someone just part of her service. And she wasn't even there that day. But they kind of responded to this by having a therapist come and a psychiatrist and have everyone on the team have opportunity to speak with them and kind of have group sessions and do all this. And I was sitting there as an ER doctor saying, like, we never get this. People die every day. It's crazy. But I think it's this funny thought process that people think that because we're around it all the time and it's common for us that we're somehow used to it or it's normal. But it's the opposite. I would say it compounds, and these things kind of, you see it all the time and it never gets addressed. So I do have that criticism against our system. And actually,
And would that type of thing be helpful with bringing in therapists or
Well, yeah,
helping
it would be.
having group sessions?
I think it would be. So I've never seen a therapist in my life, but then during COVID, there was a group of therapists that got together and kind of offered their services to ER doctors. It was this idea that they couldn't work in the ER at that time, but they wanted to work somehow, so they offered free services for any ER doctor that wanted. So the text message chain that you referred to, of all the 15 ER doctors that I'm friends with across the country, they kind of share this information. So I said, hey, I'll reach out to these people, so I started talking to them. And my goodness, it was great.
Turns out.
It was really helpful. So I think that's certainly one thing. And actually, I teach at medical school every Wednesday, and I brought this up with my medical students once of what can we do, just to kind of pick their brains, but also as a genuine question. And one of them, she's from Venezuela, and she said in Venezuela, when you start med school, every doctor is assigned a therapist, every medical student, and you have to meet with them every so often throughout your training, and then when you're a doctor as well, which I thought was really fascinating, and it's kind of head and shoulders above where we're at here. So that's one example. I think also we could just acknowledge it. I don't think it's crazy to ask for that, and I do think it's just this cultural thing where medicine is it's just this apprenticeship model where we just see what other people have done and we do what they do, and no one's ever dealt with this, so we don't deal with it. It's just this terrible cyclic event. And I told this story earlier, but I do recall about 2 or 3 years ago now, I had a trainee, a resident that I was working with, and I was supposed to be training him, and he was in the hierarchy learning from me. But then we had a patient that died, and then he just kind of stepped up and he said, hey, will no one step out of the room? Well, everyone stay in the room for a second. I just want to say that this gentleman here, we don't know his name, he came in as an anonymous person, but he did die, and just as we have people in our lives that love us and that we love, we can assume that this gentleman had people in his life that he loved and who loved him. So in recognition of that, can we please have a moment of silence? And I remember word for word because ever since I saw that, I've been repeating it, so I started doing it. And it's remarkable because you could tell once he did that, I'd never seen that before, and I've been doing this for about 10 years now, and kind of it was the striking thing, just the recognition of it just changed the tone in the room. And then ever since I started copying him, my trainee, and just doing it every time this experience happens where I work now, I'll have at least 1 or 2 nurses come up to me afterwards and say, thank you so much, that was really important that you did that. And you just realize there's this need that we're just not even addressing. So this is just one random thing I happened to learn from this one random resident for this one interaction. And if we could just start this dialogue and actually thinking about it, like think of all the things we could do, because this just happened.
Well, that's the benefit of the apprenticeship model. You could change it. So there's one chapter where you compare what you can do as a doctor to what a dog can do, a happy dog with a wagging tail can do. Can you walk us through that and kind of the thinking there?
Yeah, it's a game I call medical degree versus puppy dog. Saying who's better at this job. And it's a kind of a tongue-in-cheek game I played. So where I used to work, we used to work with scribes. Who scribes they follow you around and they document your conversation that you have and they put the note in, so it takes a little bit of the load of the paperwork off your system, off your shoulders. So you end up spending the whole day with this one person and you have a relationship with them. So me and the scribe I used to work with, we used to play this game, medical degree versus puppy dog, where we walk out the room and say, who would have won that, who would have done better there, and she would say, either you would have got that or a dog would have been better than you. And it's kind of tongue-in-cheek, but it gets at a serious thing where the modern ER is a kind of funny place where people walk in and you could do a lot to help them, but you just see so many people are just so unsatisfied and that they're right to be. We don't really meet a lot of people's needs really well. And people end up just being frustrated at the end of the day. You might have done a lot to help them, or you might have not done that much if they had an ankle sprain or a common cold, but they just end up frustrated, and you realize that a dog might not have been able to do a lot of the things that we would do, but actually they would have been less frustrated at the end of the day if they got to spend some time with the dog than me. And it's just because I recognize that need, but because of the way the ER is, you're just so busy, so overworked, so overburdened, there's so many patients to be seen, there's so little time, that you recognize that this patient has ankle sprain, and they're going to be fine, but they just need someone to sit down and talk to, and someone to listen to them, and be with them for a little bit. And then you also realize that you don't have that time because 3 other people need to be seen immediately. So you recognize that this person has this need. You recognize that they'll be much happier if you sit down and talk to them. And you also recognize that you can't do that. And it just becomes this very frustrating experience for the patient and for the provider on the other end. And that's how that game started, just because this is, hey, what am I doing here? I put all this work in and my dog would have been better.
So, tell me, I don't know if you know, but in Massachusetts they're starting these kind of community behavioral health centers, and one of their functions is to be an ER for mental illness and substance use, such that they don't go to the regular ER. I'm curious what you think of this, especially with the kind of puppy dog idea in mind of like maybe different issues should go to different, it shouldn't all be concentrated. This is very new in Massachusetts, so it's kind of, I don't know if there's an outcome yet, but I'm curious what you think of that type of model.
Well, I think that the ER is a funny place because it just ends up as a place where people go to that have nowhere else to go to. So I think for a lot of things, if we establish somewhere, most of the things that come to an ER are not best served in an ER. Emergencies are. Almost everything else isn't. Anything that could be addressed somewhere else should be, is the right rule of thumb. And so I'm all for anything like that. And I think the patients would be happier and better served. Because, I didn't know this before I went to medicine. I had no one medical in my family, and I didn't understand the basic principles of how our medical system functions. I used to think, you're a doctor and this person's a doctor, so you guys can both give me the same answers. But as an ER doctor, I only have a very limited set of tools and a limited role. What I do is make sure that you're not actively dying. And as long as that's the case, I refer you to go follow up with someone else. I'm not going to solve your problem most of the time. So a lot of the things that come to me, the patients get frustrated because they're saying, hey, my problem isn't solved. And I say, I know, but we can't solve that problem here. So yeah, I think that's a great idea.
So I was reading this book and I happened to see a friend who works at one of the big hospital systems here. She's a lawyer, and I explained the kind of basics, that there's a woman who comes in who's essentially, there's no chance that she's going to make it, but yet you give her almost everything you got.
Yeah.
And her reaction was like, that's a crazy use of resources. But in your book, you also point out these hospital systems are making other crazy decisions about their resources, or seemingly crazy in terms of advertising budgets versus hiring nurses and doctors.
Yeah.
How do you think about the resource allocation while you go through your daily life?
Yeah, I think any hospital chain, anyone that says that from a hospital is severely misguided. I think 5 minutes of working on a patient for a good reason for their family member perhaps benefiting from it is well worth it. I think I worked for institutions that have advertised on Super Bowl, where a 30-second ad costs $1 million. I work for institutions that advertise in the Academy Awards, that have billboards in Times Square, that, I live in New Hampshire now, and I do the crossword puzzle in Sunday Magazine, the Times. On the back, there's always an ad for, Mount Sinai or NYU or Northwell. I'm like, I'm 300 miles away from that. I don't know why I'm getting these ads, and it's so wasteful. But they're going to justify it because they have this kind of motto called no margin, no mission, where they say you have to make the money first, and then you put those resources into taking care of patients. So I think until we address kind of the fundamentals, I don't think 5 minutes of extra work on a patient who died is the worst of our problems.
Can you talk to me about writing the book? It's an incredibly easy read in that the pages could just flow, which is not always the case. And so kudos to you. But what was the process? We heard about the beginning, but the process took years?
Yeah, no, I didn't really intend to write a book. I kind of just started writing for myself, and it was never on my radar to write a book. But then I just kept writing, and I was talking with a friend one time, and I was encouraging her to write, and she said she couldn't write because the moment she walks out of the ER, she's an ER doctor, she's brilliant, and the moment she walks out of the ER, she said, I forget all my stories, I wouldn't even know where to start. I just kind of dismiss this when I walk out the door so I can live my life. And then I was like, no, you don't. That's totally a lie. You might not remember them, but they're deep in you, and you just don't realize it until you start kind of thinking about it. And then we started talking more, and all these stories came out of her with full detail. So that was my process with the book. I started writing, and then, I have stories in this book from medical school that I didn't know that I remembered. But then you just write, and then more stories come out, and then connect more dots, and more things come out, and then I just kept writing. And I didn't know the process of writing a book or reaching out to a publishing house or anything. I just kept writing. And then I thought it was just going to be a very sophisticated diary or something. And then one day kind of just was like, hey, this is now long enough where I think it could become a book. So then I learned how to pitch it and see what happened. But it very much was intended as just this personal project at first.
And tell me about the editing process. Did you, I'm curious mostly because when reading it, it flows and you move between time periods very kind of smoothly. Yeah. Did you go back and kind of organize it, or what was the shaping process?
I wish I had a good answer for that. I didn't know what I was doing, so I just kept writing. Everything kind of just came together and fell together really nicely. And I don't think it's because I was smart about it. I think it's just because I was subconsciously thinking about all these topics and all these things for years, right? The book took me, a few years to write, but really it was just 10 years of thinking about this nonstop without realizing I was thinking about it. So everything was in there, and it all tied together, not because I was brilliant and knew where to place it, but just because it all was already tied together. It was already, all these things were percolating, all these themes were connecting without me realizing it, and then it just kind of came out. I wish I had a better answer to that of how I put it together, but I don't know.
Tell me, did you ever think about, so Lola's this main woman who passed away, and you talked to her husband about it. Did you ever think about tracking him down and talking with him and kind of?
I did, especially towards the end when I realized this was going to come out, and everything is kind of totally anonymized, so ages were changed a little bit, genders and occupations and everything, anything identifying was changed, so I don't think if he read this, he would even recognize it. Actually, I think my fear towards the end was that I changed it enough that someone else who met the criteria would think it's them. When I was totally just randomly made up. And I did want to reach out to him, but our job in the ER is a little funny because you see a patient or you have an interaction one time and you just never see him again. So this now was years ago, and I just kept racking my brain how I could get in touch with him, but there was no way. I just had no way to do it.
You could do it.
Well, you're a journalist. You probably have better
I bet you
techniques
could.
than
I bet you could.
I couldn't think of a way. It was just it was so long ago, and I didn't write anything down in terms of her name, her medical record number. I don't even know how I track her down. And I did think about kind of what it's like to write about someone and not have them really know about it, because they're as much part of it as anyone else. It's about them, even if they don't know that it's them, or they don't know that the book's coming out. But I once heard Danielle Osprey, she's a physician and an author as well, and she said about this concern of kind of saying, so if you write about all of your patients in a way that if they read it, they would kind of see themselves in a good light, then it's okay to do it. If they would not feel flattered, but just kind of feel kind of, if they would see, if they saw that and would recognize themselves, and you can imagine that they would feel good about it, then it's acceptable in that way. So I tried to make sure that everyone was presented, even the cranky patients, presented in a good light.
Do you ever think about if he called, what you would say?
Oh my goodness, I mean, no, I didn't think about it, but I would, you know, I remember him, and I remember interacting with him, and I just remember, like, he was just a good, decent person. So, I don't know that I would say anything. I don't know that I said anything useful in real time. I just think it's sitting there and more listening than saying anything. If someone goes through something like that, there's nothing.
Yeah.
You say a lot of things that you're trained to say, and you go through the process, and there's all these things, ask, tell, ask is the strategy we have to break bad news, and then we have all these other kind of algorithms to tell bad news. But at the end of the day, when something like that happens, you're really just listening more than anything. You're just being there, and it's just a human thing. So I don't know that I would say much.
And tell me, you still practice?
Yeah.
Okay. How has writing this book and spending this time thinking in detail about one relatively short interaction changed how you practice and see patients now?
I mean, I think it's so easy to have a patient interaction and kind of, they all blend together because you're moving so quick and you're seeing so many patients, but then when you realize how much this one story or any one story in the book affected you, you realize it's that them on steroids. So you just, every once in a while, and I hate saying this because I feel like it gives off the impression that if only doctors slow down, that you'd be a good doctor, but the system doesn't allow you to do that. But then I do think it's important every once in a while you just stop what you're doing and just say, there's other people waiting, and some of them are quite sick, and I do need to attend to them, but I just gotta slow down for like 45 seconds for this person. And I think that makes a big difference, as corny as it is.
Can I ask one more question, which you don't have to answer, but I was curious while reading it. A lot of doctors I know and have chatted with are themselves do not resuscitate. Do you have thoughts on this? Are you?
I'm not, but I'm 37.
Yeah.
I got a way to go.
Yeah.
But I mean, informally, Vivian and I have spoken that I don't have a blanket DNR because, I mean, if I get into a car accident and, you know, they intubate me, but I'll be fine in like a month, I'm like, do it, like, that's fine. But if it's a circumstance where I'm going to be brain dead and I'm never getting off the ventilator, yeah, she knows what to do. So yeah, but I think it's a good point.
Performing it, I was thinking, like, how is this impacted?
No, I think it's a good point. I think the people that want the least done are usually the people who see it the most. And then it's always the people that want everything done, quote unquote, is the son or daughter that lives in California that doesn't know what's going on really, and doesn't see how brutal it is and how awful of an experience it is. So it's a reasonable question. And, I mean, yes, I kind of am. Not blanket, but she knows.
I would love to hear if people have questions. While you're thinking of them, raise your hand, but I just want to hear, you've just produced this awesome book. What's next? Are you going to keep writing as you keep practicing, or what are your thoughts?
I'm definitely going to keep writing just because I don't feel like I have a choice about that. I feel like I need to. But when you have a book come out, a lot of people refer to it as, you've been working on this for so long, your baby is going to be coming out soon. And it's true, I mean, it is my baby, but my wife's 39 weeks pregnant, so I'm going to focus on the baby and kind of put this aside for a little bit and focus on what matters.
Yeah. Wonderful. Questions? Thoughts?
Okay, perfect. Thank
Reactions?
you.
Some of you work in the ER, right? Because I see some thought there. Even if it's not a question, feel free to. Yeah.
How would you characterize the mental toll that you reference? Is it like an implicit experience to be in the emergency room, or is it specific to just like the duration? Do you feel like every person who works in the ER would experience this at some level?
I think so. I think you necessarily have to, and I think that a lot of people just refuse to acknowledge it. And I'm not saying it's debilitating or my life is awful because of it, but I think it's there, and it's just dishonest to act like it's not. And I think there's this culture to act like it's not, but it's just dishonest. You can't, and all things aren't equal. It sounds a little messed up, but there's a way to internalize an 86-year-old person that has end-stage cancer and they die. It's bothersome, but it feels understandable. But when you work in the ER, you see all sorts of horrible things. You see, a child that their family dog bit their face and the kid died, and we see stuff like that. You see horrible things all the time. And, I don't think whoever you are, you can see a child die in that way and not be affected. I just don't buy it. And if you are, maybe, I don't think that's okay either. There's something messed up there. So yeah, there's something implicit in working in that circumstance that I think just needs to be at least discussed.
Thank you.
I just have kind of a comment question, but you're talking about this sort of apprenticeship medicine, but all the people you've mentioned that you learned from were your trainees, your medical students.
Yeah.
You're mentioning these younger people that are teaching you, so I appreciate just seeing that shift, I think kind of with our generation and with this upcoming generation of medical students and trainees. Do you feel that shift at all? Or
Oh,
do you
totally.
think it's still much more kind of this patriarchal?
No, I love it. I teach every Wednesday, and this year I was kind of surprised. I kind of introduced myself, and all the students just started calling me Farzon, and I loved it. Usually, they call you Dr. Nahvi, and you have to correct them and say, no, Farzon. But they just have a very different sensibility now, and I think that they have so much to offer, and I love that sensibility. And they kind of, I feel like, I'm not that old, but at least in my generation, we would kind of say if someone told us what to do, I would just say okay and take their word for it. Whereas they're much less willing to just accept what you're saying now, which is fantastic, and they challenge you a little bit, and it's wonderful. There's a lot to learn. Are you in medicine?
I am, yeah.
What do you do?
I'm a nurse practitioner.
Oh, wonderful. Yeah.
Yeah.
Do you have the same experience? Or-
Yes.
Yeah. Yeah, it was great.
Yeah.
I was going to say, I read the book in one evening, and I have not read a book in years. And my favorite part was when you talk about the expired. So I'm not a native speaker, so when I first started working in VR, I would see the expired on the medical record at Epic,
Yeah.
and I would always think, why does it say that? They're dead. So essentially, the medical record says expired. In the book, it's also mentioned that, everyone starts referring to people that have died as, this person expired. And I always thought that was bizarre, to the point where I thought that the medical record expired, and that's why it's yeah, but I feel like it was something that I always thought was weird and inhumane that I never talked about, and it felt so good that somebody else also thought about it.
Thank you.
Yeah.
Yeah, I appreciate that. No, I think there's just so many things like that in medicine. I think medicine's this weird world that you go into it and you just immediately thrown into all these bizarre and kind of messed up circumstances, and they're just left completely unaddressed. Which is why I wanted to write, because I just want to. I've been doing it long enough now where I realize I'm starting to kind of co-opt those just accepting the way things are, and that scares me. I don't want to. I just want to keep my human sensibilities, and for me, this book and writing about was a part of that. Just, no, like, you're not wrong, the system's wrong, that's messed up, and just don't forget that, and just keeping that. Just because you could lose that so quick. But yeah, no, I totally agree.
I also had a question about medical students too, because you mentioned that you work with medical students every week, and presumably before they've gone and worked in hospital, they're innocent and bright-eyed and bushy-tailed, and they don't have this sense of what real life is like.
They do. They have a better sense of what real life is like than we do. They don't have a sense of what real medicine is like.
Fair, real medicine. But I'm curious what you tell medical students in order to, keep that positive energy and their excitement for caring about people while preparing them for real medicine too. What do you tell them?
I sometimes wonder what my medical students actually think of me, because I repeatedly tell them every week over and over that, like, this is what I'm telling you, but I don't know. and I hope they don't think I just am stupid and don't know anything. But I just tell them that, look, this is what I'm teaching you, but I don't know that this is the right answer, and it's up to you to kind of figure that out for all of us. And kind of reminding them over and over what I do is say that, I am the expert on emergency medicine and resuscitation and these specific things, but that does not make me the expert on anything else. And you are going to be the expert on all the other things, and you are equal in any other. If you want to challenge me on anything, like, you should. And just kind of reminding them that the people in medicine will teach you a lot of things, and you should listen to everything they teach you about medicine and not necessarily anything else. Because they're not experts on that. It's just kind of what is done, and not because it's done for a good reason.
Do you worry that they'll be blindsided by the hard realities, like being put in these situations?
I do, and that was the first thing I tell them on day one of class in July. Is always the first thing I tell them is that I'm going to be totally honest with you about everything, because I got very blindsided, and I'm sure anyone here that's in medicine, you get taught these things and these platitudes, and then you start working, and the same institution that teaches you those things is then going to employ you, and they don't want you to do any of those things. And it's all fake. And
What's an example?
so an example is you come in and you see a patient, and you have to ask them their medical complaint, their family history for diseases, their social history, who they live with, who their spouse is, how many children they have, their sexual history, and then you get out there, you say, okay, you have 4 minutes to do all that. You're not going to do it. Or they teach you all these things to do an exam, and you have all these sophisticated techniques to do an exam, but no one ever does that in the real world, and the reason is you don't have the time. So I'll teach at Dartmouth, and I'll teach the students a list of things that they need to do, but then they go and get a job at Dartmouth as a doctor, and they can't do any of those things, and it blindsides you, and it says, why'd you guys teach me all this if none of it's important, if we're not doing it? So I think that's confusing, and either it's important and we should be doing it, and you, Dartmouth as the employer, are wrong, or it was never important and you, Dartmouth as a medical school, was wrong. But they can't both be true. So I forgot the question, sorry.
About if you worry they'll be blindsided.
I do, yeah. So my instinct is always just to say, I'm teaching you this, but this is not necessarily what reality is like, just to let you know. And I think it's frustrating for them to hear, but I'd rather it be frustrating in real time than frustrating the way I found it to be later on. So I do worry about that a lot, just because I found that experience annoying.
How about burnout? What could you do to I feel like I know a lot of doctors who have
Yeah.
actually left the profession not that long after
Yeah.
entering
Yeah.
it, after years of work.
Yeah, no, I mean, I think burnout is a very complicated topic, but my main thoughts on burnout is that it needs to be addressed at a systemic level. I think this year's most recent survey with that 65% of emergency physicians are burnt out. I mean, once I had a professor in college for human behavior class that I took, and then he was going through different cultures around the world, and he says if every culture does something differently, if they have different food, different dance, that's a cultural thing. But if every culture does something the same way, that's a human thing. So you apply that idea to this, if 65% of ER doctors are burnt out, that's not a doctor problem, that's a healthcare system problem. So I think that it needs, and the reason I bring this up and say that is because I feel like the idea of burnout's in the news all the time now, and then institutions and always coming up with, hey, we'll provide you with this yoga session, or why don't you consider kind of these breathing techniques, or they'll have individuals try to focus on how they could deal with the burnout, and that's never going to be the solution. If so many people are burnt out, there's a systemic problem, and the only way to resolve it is through a systemic solution. And I think that's an important understanding of burnout. And I think all it comes down to for me is the discrepancy of support from the institution versus what you're doing. I think it's very difficult to put your heart and soul into something necessarily because you're working with people who need that, and then have your institution not support you as much as they need to. And I think that's the root of the burnout, and I think the only solution is to have the institutions support us a little bit better.
And what's the support look like?
Support means more time, and more time usually means more staffing. I think have enough staff that everyone can take the time to do their job right. So you're not feeling that. It's just I got a bunch of emails last week from a lot of people, and someone emailed me and they had a phrase of systemic betrayal of our healthcare system towards the providers, and I think that was a very beautiful phrasing that I heard. I think that there's a systemic betrayal as part of our healthcare system, and until that systemic betrayal is addressed, I don't think burnout's going to be addressed. I don't know. A lot of people here in healthcare. What do you guys think?
So in part of the book, you talk a little bit about learning the story of a patient versus not learning the story of a patient, and how learning versus not learning is what makes medicine, because if you don't know who the person is, then you're just, suturing a leg, effectively. And you talk about the internal conflict of, do I learn the story and then what do I do with it, kind of thing. Can you say a little bit more about the importance of the story and what I think you're talking a lot about, the systemic aspect of it.
Yeah.
Within the system as it is, what do you do with that story?
Well, I think the story is what makes the job interesting. I think you have to, you're dealing with people. And I think when you interact with people, you have to talk to people as people, and otherwise the job gets kind of boring. They're a chest pain patient or they're abdominal pain patient, but if it's a person that's telling you a story about who they are, what brought them in, and why they waited so long or why they didn't, it just becomes more interesting, and I think you need to do that. But the chapter you're referring to is kind of, sometimes there's a lot of sordid stories out there. A lot of what we see, especially in the ER, is kind of really heavy, sad stuff. So while it makes it more interesting, there's kind of a threshold where you say, hey, I don't want to hear another story like this for a while. So it becomes this tightrope walk, I think, for me, where I'm so eager to just chat and have these stories, but then every once in a while, I think I need a break, just because they get a little heavy. I don't know if that's your experience too.
Yeah, I guess where I was going was you need a break. The break's not available because there's a systemic barrier to it, right? So then when
Yeah, no, I don't know that there's a good solution, but I think that's why people are burnt out. I think that our system doesn't allow for that, so I have a personal solution, which is to write a book, but I don't think that's universally applicable. So I don't know that there is, within our system, an obvious universal solution to that. Otherwise, people would have figured it out, and there's a reason that the problem exists the way it does. And that's why I say it necessarily needs a systemic response to address it.
Any last?
Which I think can come, by the way. I think it can come with advocacy.
Really?
No, really. I think that like people have been burnt out for a long time, but in the past few years, people are talking about it. You just kind of brought that up spontaneously, and I think it's on people's mindset now. People recognize that people that work in healthcare are burnt out. So I think the dialogue has changed. I think in January, a bunch of nurses in New York at Mount Sinai and Montefiore, they went on strike, and they won. They got everything they wanted. And then on top of that, when I was reading the news articles about them, all the comments and the way the news articles were written were largely supportive of their efforts. And I think that a few years ago, people would have said, you know, I can't believe these nurses are striking, the patients need their help. But I think the commentary this time was, you know, good for these nurses, the institutions are failing them. So things, I think, can change, and it might not come from legislation, it might come from people striking, and that's important too.
Is that a result of COVID?
I think the COVID, again, is kind of my on-brand answer. COVID was that clarifying lens.
Yeah.
But I think COVID made people realize their worth and realize that, you know, they can do that and they deserve it. And I think society looks at nurses and doctors, especially nurses, differently now because of kind of that highlighting lens of COVID. So, yeah.
And it sounds like you're optimistic about things changing or improving. Is that fair?
I'm optimistic only because I'm necessarily optimistic. Not that I necessarily think that it will anytime soon, but I think that it has to, just because the status quo can't continue. So I think that I just can't imagine things breaking down further. So things seem impossible until they aren't. Right? I've been around long enough that, you know, there's enough things that gay marriage was never going to happen in America until it was the law of the land, right? Roe v. Wade was not going to be overturned until it did, right? Things seem impossible until they happen. So I think there's not necessarily a lot to say that this is going to happen, but I think it will nevertheless, because it has to. And people are paying attention.
Thank you so much. Thank you for writing the book.